All right, good morning, everyone. It's 11:08. You're almost to lunchtime. It'll come. There's a light at the end of the tunnel. My talk is about, I'm Scott Gailey. I'm one of the knee and hip surgeons, arthroplasty surgeons in town. Really new to the team, excited to be here in the northern Colorado area. It's been a fantastic start. And I'm here to talk a little bit about robots, and really this talk is going to focus on knee arthroplasty. Robots are being used in both knee and hip arthroplasty, and now shoulders. But really they've gotten their start in knee arthroplasty, and that's where I think a vast majority of robots are being used now. So let's see if this works. Unfortunately, I have no disclosures, no conflicts of interest. So just as an overview, I think we need to talk about what's wrong with knee surgery that we need robots. Every time I think that I'm approached by a rep or a device company and they say, hey, we've got this great new thing, my first question I ask myself is, do we have a problem that needs a solution, or is this a solution looking for a problem? And I think that's an important thing to keep in mind as we think about robots in knee replacement. I'll lead you all on a brief foray into the weeds of knee replacement. I'm really going to nerd out on some of the things that we do in surgery. I'll try and keep it high level enough that I don't lose anyone. But I think it's important to know kind of the basics of what we're trying to accomplish and how it's done, so you guys can understand the role that robots can play in the surgery. And then we'll talk exactly about that. What are the robots doing in knee surgery? A lot of patients will come into my clinic and say, oh, you do robotics. What are you doing during surgery? Well, I'm doing the surgery. The robot's just a tool. And I'll kind of illustrate that for you. And then I'll talk about a little bit where I think knee replacement is headed in the next 10 to 25 years as robots kind of mature and we get more technology into our operating rooms. Just quickly, I won't make you guys do this the entire talk, but obviously, who here has heard a lot from their patients or is familiar or sees marketing materials about robotics and knee replacement? Just quick show of hands. Okay, so everyone, no one lives under a rock here. Quickly, who has an overall good impression of knee replacement robotics? Like they would only allow their family member to get a robotic knee, or they think it's the greatest thing? No one? Okay. Who thinks it's the worst thing and wouldn't send anyone, or would highly recommend against it? And then who's confused and really just doesn't know? And okay, I'm with all of you guys. So we really don't know yet, and I don't think this talk is going to sway you into one camp or the other, but hopefully we'll just, as Dr. Gray referred to, it's the more I learn about this, the less I know. And who knows what the future holds. So as I alluded to, what's the problem, the open secret in knee replacement? This is a finding that's been reproduced in multiple papers, which is, sorry for the small graph here, but if you look, this is patients who are overall very dissatisfied, or neutral about their knee replacement. If you add all these numbers up, that's about 8% that are very dissatisfied. Dissatisfied is about 5%. Another 8% are just neutral. So I don't know about you guys, but I don't want my patients coming back and being like, meh, I'm no better, I'm pretty neutral about it. I want them to be either satisfied or very satisfied. So this is consistent about all these studies that look at the satisfaction rates after knee replacement, about 1 out of every 5 patients is either dissatisfied or really could take it or leave it. And this is something we talk about at our national meetings all the time. Each individual knee surgeon you talk to would say, well, that's in a population level, that's not my patients. But the humility is that our patients tell us different things than they objectively tell other people that aren't invested. And I don't know, it doesn't seem like 1 out of every 5 of my patients are dissatisfied, but certainly that's what the research shows. So why is that? So why aren't 1 in 5 happy? Well, there's some ideas that it's some socioeconomic factors. I call these the blame the system factors. Lots of research been done into various aspects of patients' pre-existing conditions and the operating room environment and post-operative care, and this is kind of what we found over a lot of studies and papers, that living alone, race, low BMI are associated with dissatisfaction. Things like age, sex, education, income, employment, insurance status are not. Preoperative factors, I call these the blame the patient factors. Less severe arthritis, really benign x-rays before they head to the operating room are associated with dissatisfaction. Patients with pain everywhere, the fibromyalgia type patients who start yelping as soon as you brush their skin, those patients, not surprisingly, are often dissatisfied with their knee replacements. Also people with depression and pre-existing psychiatric issues. And then I call the last group the intraoperative factors, the blame the surgeon factors. For me, these are the ones I'm most interested in, especially as a newer, younger surgeon. I haven't been around for 20 years. I don't have my ways set yet. I want to know, how can I be better? How can I make sure that I'm maximizing my treatment for these patients so they can get out of the operating room happy? And so we've looked at a lot of things that happen in the actual operative care episode. And surprisingly, you think over the last 25 years, we've had all these fancy implants. They're out in the hallway there. You can take a look at them. They're nice and shiny. There's been a lot of improvements in those, especially in hip replacement. But in knee replacement, it really doesn't seem to show any trends that these newer implants lead to any better outcomes or improved satisfaction rates. Tourniquet use, something we talk about all the time. I'm sure, especially in physical therapy, you guys see patients who say, oh man, my proximal thigh is just killing me, but my knee's not that bad. Well, again, overall, in the long term, not associated with satisfaction. Incision length, soft tissue releases, patellar resurfacing, all of these intraoperative factors, not necessarily tied to patient satisfaction. Now, I kind of cherry-picked some data here, but there are certainly some studies showing that implant alignment and the size of the bony resections that the surgeon makes during surgery are associated with patient satisfaction. So just keep that in your head as we keep talking. I think one of the biggest things to understand as we start delving into the world of knee replacement is that the model of the knee that we learned in 4th or 5th grade health class is just a bending hinge is not correct. The knee's much more complex than that. All of you guys who are physical therapists, kinesiologists know the mechanics of the knee are not so straightforward as just a bending hinge. They bend, no doubt, but they also roll. So you have this rollback movement as the knee goes into deeper flexion. The contact point between the tibia and the femur rolls back on the tibia. And then they also pivot. So if you're looking down on an axial view of the top of the tibia, over here we have the contact point of the medial femoral condyle, and here's the contact point of the lateral femoral condyle. So there's also a pivoting mechanism that as with deeper flexion, the lateral femoral condyle creeps back on that tibia much more so than that medial femoral condyle. So it's a complex three-dimensional movement of the knee that's a lot more difficult to explain or reproduce, and there's a lot of soft tissue interactions and ligaments at various tensions as this knee goes through this motion. And this is what a normal 20-year-old knee functions like. And so the patients who come into my clinic, similar to Dr. Ben's, I tell them, I'm not giving you your 20-year-old knee back. I mean, it's pretty functional. You can go skiing, you can do all sorts of things. But oftentimes I try to prep them that the mechanics of your knee won't be exactly like the mechanics of your knee when they're 20, and I'm trying to say that in much more layman's terms. So what are the basics of knee replacement? Well, a lot of you guys probably know this, but it's a resurfacing procedure. I tell patients all the time, replacement's a little bit of a misnomer. It's a resurfacing procedure. We take out the worn out cartilage and bone ends and we replace them with metal and plastic. That's a pretty simple definition. Our goals are to resurface the joint, restore function and mechanics, and relieve pain. Simple enough. This is where it gets tricky. Intraoperatively, we have to balance our bony cuts with the implants that we're about to put in, their thicknesses and their associated sizes. We have to evaluate their soft tissue tensions. We have to figure out their native alignment as well as any deformities that have resulted from their arthritic process. So here's it started a little early. Here's a little animation of just showing a worn out knee and kind of the basic cuts. You don't have to worry about the specifics of what's going on here, but here's a terribly worn out knee, supraarthritic, loss of cartilage, bone-on-bone arthritis, osteophytes. And really the surgery is making a series of cuts, 5 separate cuts on the end of the femur. The anterior, posterior cut, the distal femur cut, the chamfer cuts are those angulated ones at the end. And then just to get it ready for the implant placement, on the top of the tibia we make a straight cut across the top of the tibia to get it ready for the tibial tray, which you'll see sneak in here in a second. And then once we resurface most of these bones with the metal cap, there's the tibial tray, we sandwich a piece of plastic into them, and that's highly cross-linked polyethylene. So that's just the very bare bones basics, and I'll kind of allude to this. And then oftentimes, especially in the United States, we most commonly resurface the underside of the patella. So these are those cuts, again, demonstrated from the sagittal plane. And just to demonstrate, I'm planning, eventually I'm going to put an implant in there, and these implants all have a set thickness that are, vary by manufacturer. Most of them are about 9 millimeters. So as I'm making these cuts, I both have to account for what I'm about to place back into the knee, as well as the soft tissue tension that's pre-existing in the knee before and during the surgery, as things change as you make cuts. So again, coming back to this idea of balancing out my cuts, balancing out the ligaments, and eventually what I'm going to put in. If this is looking now from a coronal plane or straight on at the patient, when their knee's extended, I'm about to cut the end of the femur and the top of the tibia, and it's going to make hopefully a rectangular box where I can fit in my implants. Same thing when the knee's flexed. I'm going to cut the back of the knee, and the top of the tibia cut also affects this gap. Again, I don't want a nice rectangle so that my MCL and my LCL are evenly tensioned on both sides, and I don't have a loosey-goosey knee. If I make the flexion gap way too tight and it's a lot smaller than this extension gap, then those are the patients, at least from a technical issue. One, the patients that you're seeing in your clinics who can't get their flexion back. One, they're either having a ton of swelling, they're unmotivated, they're hypersensitized, or the surgeon made a technical mistake during surgery and overstuffed the flexion gap, and they're stretching their ligaments to try and get to that flexion point. So how is a manual TKA done? I think this is important to note because we have to contrast robotics with something. So I'll just briefly say that it's really done with a series of these metallic cutting guides and jigs. Here is how we make a distal femur cut. Oop, not ready for that yet. We make a distal femur cut. There's a rod that goes straight into the intramedullary canal of the femur, and then we typically just set how much varus or valgus we're going to cut in the end of the distal femur at like a just general anatomic average. So that's usually around 5 or 6 degrees of valgus. And that's just based off of what the typical human anatomy is. So I liken this to kind of how you used to solve this when you're a lazy fourth grader. You see this on your mathematics test, and your teacher tells you to show your work, but you're like, well, 192 is greater than 120, so I know the answer is better than 10. It's less than 240, so I don't know, it's 15 or 16. And you write 16 down, you get it right, but you do the old guess and check method, but your teacher's still mad at you because you didn't show your work. That's kind of what we're doing with manual knees. We're guessing that, okay, well, for this patient, most patients, everyone's good with a 6-degree valgus distal femur cut. And I hope that after I make all my cuts, I get those nice rectangular boxes. The truth is that you don't know until after those cuts are made whether or not it's going to work. And you don't know until after you guess if you can check and see if that number's right. So that's kind of how I liken it. Right now, we're just guessing and checking after the cuts are made based off of kind of experience and kind of all the wisdom we've been passed down from our previous surgeons and teachers. And I think the failure of that method, at least my criticism is here's one of my patients who I took to the operating room a couple months ago. We operated on her right knee. This is an incredibly varus right knee. She's very bow-legged. This MCL is going to be screaming tight. She's been sitting in varus and bow-legged for years. That MCL is contracted. This LCL, you can see the gapping in the lateral joint. This LCL is going to be super stretched out. This is a fundamentally very different knee than this patient on the left, or a patient's knee on the left. They're two totally different problems. They're actually mirror images of each other. It's going to be the opposite. LCL is going to be extremely tight. This MCL is going to be lax. I'm going to have different bony defects in each knee. And to just say that one solution fits all, one 6-degree distal femur cut works and one mechanical alignment on the top of the tibia works is going to balance them out, I just don't buy it. And oftentimes surgeons have to chase their own cuts by doing soft tissue releases, which are very unpredictable and can lead to bigger problems. All right, so finally I'll get to robots. What are robots doing? So I think it's important to know the anatomy of a robot. They look generally something like this. Now each company has its own proprietary system with various solutions and imaging that has to go in beforehand, but overall they have some sort of infrared camera and then some sort of robotic cutting arm. So most of them are sitting on a big giant base like this, and they've got these computer screens that help us with pre-planning and what we're doing in surgery and visualizing things. But this is generally the system. Another company has one that snaps on the side of the bed, but overall there's some sort of infrared camera and there's some sort of cutting arm or robot arm that helps align things. In the patient, what you'll see is they have these pins that go into their femur and the tibia. There's various ways to do this, but overall these little infrared reflectors are placed on these pins, and then this infrared camera is tracking these arrays throughout the surgery. as their fixed points on the femur and tibia where it can build the model of the knee off of. So this is what it looks like in the operating room. This is a case I was doing, and this is where the robot's sitting. So to the answer to the patient's question, you know, the robot's often just hanging out near the head while I'm making cuts or stuff. But again, here you can see that infrared camera looking at things. You can see the hints of a pins over here, and the robot arm that'll come in and out of the surgery as needed. So in general, there's 3 steps of doing a robotic knee. One, we register the knee. So we're building a 3D virtual model of the knee in the computer system to model the joint as it exists in this specific patient with all of their individualized anatomy. We assess the joint, so I'll stress the knee, I'll stress it in varus and valgus, and it'll tell me how much laxity I have on the medial side and the lateral side, and allow me to understand how exactly this patient's soft tissues are behaving in this specific surgery. And then I can plan, and then I think this is the real powerful part of robotic total knee replacement. I can virtually do the surgery on the screen before I ever make a cut on the patient. And I can have some predictability that when I end up making those cuts that I'm planning, I'm either going to be too tight, too loose, or hopefully, if I planned it correctly, balanced perfectly so this patient gets a nice gliding, smooth knee that works both well in extension and flexion. So there's going to be a lot of information on these screens. These are actual screenshots from one of our programs, but this is the registration phase. I've got a little pointer array with a bunch of infrared markers on it, and I'm pointing at all of these specific landmarks on the femur and the tibia. And again, it's building a 3D virtual model of that patient's knee in the computer. And then this is the assessment phase. So again, a lot of information here. This is just telling me kind of where the patient's knee is and its overall alignment at what point in flexion. And then I can see how much varus or valgus I'm in at various flexion or extension intervals. And then it'll tell me how much space I have between each side of each bone. So for example, here I've got 4 millimeters on the medial side due to soft tissue laxity, 4 millimeters on the lateral side, and then same thing in flexion. It's giving me my soft tissue laxity in those specific areas too, all of which allow me to do planning. So again, a ton of information on the screen. Even surgeons who are starting to use this system get way overwhelmed by all the information on the screen. But again, it's telling me how much I'm resecting from various parts of the femur. It's telling me my overall alignment of the implants. It's showing me what how my implants are going to sit when everything's said and done. And then over here, it's telling me my gap. So for example, the component's going to be 19 millimeters thick. And right now on the medial side, my cuts and my soft tissue tension together only combined for 17 millimeters of space. So now I know, okay, well that medial side looks like it's going to be tight, or all of it looks like it's going to be tight. I can move the components around. I can change the varus valgus of the tibia. I can rotate the femur. I can do a whole lot of things in pre-op, and it's like pre-op planning in the middle of surgery. So I can figure out when these cuts are eventually made, do I have a balanced knee? No guessing and checking. So what does the research show? Again, is this a solution looking for a problem, or do we have a problem and this could be a great solution? So overall, there are certainly reproduced in many studies, there's fewer outliers, which makes sense. So these robots are very good at precisely putting these implants in where we want. And we're not ending up with a tibia that's in 7 degrees of valgus, or these outliers that can happen from human mistakes in surgery. So there's certainly lower outliers in overall alignment or misalignment of implants. Improved recovery, some studies show that, not really well demonstrated consistently. Decreased pain and complications, again, very controversial, not very well shown or demonstrated in a lot of papers. Marketing, I'd be remiss not to say that a lot of young surgeons, a lot of surgeons are using this as a marketing opportunity. Patients want this. They want to feel like, you know, they're getting the latest and greatest, and certainly a lot of surgeons see that as a way to offer something that will bring in more patients into their door. I don't think that's a good pro. That's not a good justification for use of this, but that's just the reality on the ground. For me, it's precision. I'm a very type A guy. I want to know my implants are going in exactly where they should be going in. I want to know how the case is going to end up before I walk into the room. I don't like surprises. So that's personally why I like robotics. And I think I'll also get into the future of knee arthroplasty. I think the only way we get that 1 out of 5 number down is that we know what we did and finally executed during surgery, and we can compare that to outcomes. Cons, there's certainly cons. There's increased costs. There's a big robot in there that's got to be powered on. It's got to be built. It's got to be sit in the hospital. Someone's got to run it. There's a bunch of pins and other things that have to go into the patient that cost some money. So there's a few $100s certainly per episode. Increased surgical time. That's been consistently shown in a lot of research papers. So we're not talking hours here. You know, an average knee maybe takes 45 minutes to 60 minutes. So we're adding on maybe 5 to 10 minutes per case. But, you know, that's a 20% increase in surgical time. And that is certainly a big con. There's no paper that has demonstrably shown improvements in outcomes at 1 year. I have a lot of thoughts about why we've never seen any outcomes that have shown improvements in robotics. And I think that's because, again, it's a tool, and it's based on the surgeon that's using it, right? So I tell this robot what I want it to do, and it does it. Now, if I have a bad recipe, if I have a bad idea of how I want my knees to be balanced, of course those patients, or I try to replicate my manual knees with a robot, of course there's going to be no difference. But I'll talk about why I think robots are necessary to move the field forward. And of course, there's also complaints of pin site morbidity. You can have issues where these pins are placed, small infections, sometimes fractures, very, very rare, but certainly for a procedure that's very successful, you can't really afford a lot of morbidity from other issues. So where's this going in the future? Well, I'll tell you right now, robots, and I'm sure as you guys have lived this in your clinics and otherwise, but there's been more robots over time, and it's not slowing down. So in this paper, less than 0.1% of TKAs done in 2008 were robotic. That's up to 4.3 in 2018. Now, this is old data, and right now, I tried to find the latest data, but certainly more than 30, almost 40% of knees now are being done robotically. So over the last 10 years, there's been a huge explosion in the utilization of robots. These studies projected 50% of knees will be robotic by 2030. I think that we're going to be there much sooner than that. Again, replicated in this study, less than 1% in 2015, almost 6% in 2020. That's a 601% increase, and it's only gone parabolic from there. So what's the future hold? Well, what are our patients searching? Here, I mean, you guys have lived this too. And I see this in my clinics. It's an exponential increase in the search for robotic knee arthroplasty in Google searches. So that's what patients, whether marketing materials or whatever's going on, they know about it, they're looking for it more, they're demanding it more. So on the demand side, there's certainly a lot of demand for knee replacement, for better, for worse. And also, it's what our residents are learning. It's what our academic centers, that's some of the initial places that these industries have focused on getting these robots into. They want their robots studied. They want papers coming out of these academic institutions, and guess who's sitting around there learning? Well, it's the residents, and this is just a photo of me in residency. This has nothing to do with robotics. This is my mentor, Ed McPherson. He hates robots. I just want to be able to tell him I put his photo in a robotic talk. But as these robots are sitting around and more of these attendings at these academic institutions keep doing robotic surgeries, well, that's fewer and fewer cases that those residents are learning how to do manual total knees. So it's kind of a problem that feeds onto itself. Problem or solution, I don't know. But they're coming out and they have less comfort with manual total knees. So they start becoming more and more reliant on this technology, almost like an autopilot in airplanes problem. So I think the supply side of robotics is also going to be there. So what's the future? Well, I alluded to this earlier. How are we going to solve that 20% problem? And I think the reason why we haven't made a lot of progress with the 20% being dissatisfied is that right now it's all just the surgeon, well, I think this cut needs to be here. This knee feels right. It feels good. It's all about feeling. It's about, like, in a lot of my older attendings and mentors will say it's an art, it's an art, it's an art. Well, I agree with them to an extent. I mean, this is the human body, you know, and we used to bloodlet, and, you know, phlegmons were causing problems and uteruses were causing hysteria. So you know, we have data, we have science to push the field forward, and there's atoms and molecules. It's very basic, you know, we're learning things as we go. So I don't think it's an art. I think that there is a scientific solution to this problem. We just don't have enough data, and we don't have objective quantification of what we're doing in the operating room. And that's where I think the real promise of robotics is that we can quantify and objectify what each surgeon's doing and just not rely on them to say, yeah, I did a good job on that case, that needs well balanced. We have data to show what is or isn't well balanced, and then as we accumulate all this data on tens of thousands, hundreds of thousands of patients, you're going to have massive pools of data. You pair that with AI deep learning systems that can start tying in correlations between patients and certain stresses of knees and soft tissue envelopes. And it's going to be able to pop out instructions and recipes for each individual knee that each surgeon would have no prior knowledge of or be able to predict. But this AI system's looked at tens of thousands of knees and says, hey, I've seen this knee 500 times before, and to maximize your outcomes, you should probably balance it like this. We can't do that today. We don't have that data. We don't have that objective measure. And so we currently can't figure out how to push the field forward, at least as far as mechanical alignment goes. Plus, you need a robot to execute that sort of specific recipe, and then you'll get more happy patients. You know this slide's a fraud, and that guy's not an orthopedist because he's wearing a stethoscope. So what should you tell your patients? Walking out of here, should you go preach the evangelism of robotics and send everyone my way? No. I mean, what matters still is what's always mattered. What is the surgeon's reputation in their community? Do they take good care of their patients? Do they abandon them? Do they give them the time of day? Do they talk them through the surgery? What's the rapport that each individual patient has with their surgeon? I still tell most people, like, hey, you've got to have a clicking relationship. It's a little bit of a marriage. If you have a problem, that surgeon's got to take care of you. You have to have a good rapport and trust each other. Volume is huge. And I think nowadays this is less of a concern. You don't want to send your patients to someone who dabbles in knee replacement or dabbles in hip replacement. And you also don't want to send them to the factory where they're doing thousands of knee replacements a year. So there's a little bit of a Goldilocks zone there. And I would say at minimum, a knee surgeon should be doing at least 400 to 100 knee replacements a year at minimum. I don't know the maximum. That's controversial. Training, so sure, where'd they go? What'd they train? Did they do a fellowship? What's their team like? Do they have a good team built around them? And then maybe consider robotics. So on a pie chart, this is about how important I'd say the patient's consideration of robotics should be, and it's absolutely outsized for the people who come talk to me about whether or not I do a robotic surgery. They think, well, I'm actually going to go to a different guy because I like his robot better. I think that's very silly. Anyways, thank you all. I'm going to get kicked off stage here now, but happy to ask any questions before or afterwards. Carly, do you want to set her up now, or any time for questions? A couple questions, maybe? That was a perfect talk. There's no questions. All right, thank you, guys.